Okay, good afternoon, everyone. It's really nice seeing you all again with another session of our academic cover. Today's topic is approach to a child with recurrent abdominal pain. And our resource person is none other than Dr. Rukmal Gunathilaka, Consultant Pediatrician, National Cancer Institute, Maharagama. Dr. Rukmal obtained his MBBS from the Faculty of Medicine, Colombo, and got his MD in Pediatrics from the Postgraduate Institute of Colombo. He is a member of the Royal College of Paediatricians and Child Health in United Kingdom. Also, a member of Board of Sports Medicine Sri Lanka. And he was the former Assistant Secretary of Sri Lanka College of Paediatricians. Actually, he needs no elaborate introductions as he's a character that works very closely with GMOA and an active resource person for us. So without further ado, let me welcome you, sir, to commence the lecture.
Thank you, Ranesh. Thank you, Ranesh, for that kind introduction. Good afternoon. So today I'll be talking about recurrent abdominal pain in children. So why this topic? I think what I've seen is this is a common problem that we see among children. But unfortunately, our doctors are not very confident in managing these patients. And also, when they do manage, I see sometimes these patients are not managed properly. So this is going to be a very basic lecture. There's no hi-fi things in this lecture. So much so at the end of the lecture, you might feel, okay, this fellow didn't teach us anything new. That's fine, because that is not my intention. The intention is to refresh your memory so that you manage these patients properly and that the patient outcome will be better than what we see. Okay, so as I said, recurrent abdominal pain, sometimes it might be what you would explain as a chronic abdominal pain, where the parents come and tell you the pain has been there for weeks, months, or sometimes even for years. How do you approach these patients is what we are going to talk about. But at the same time, I think the main emphasis will be on discussion about constipation, because what I see is that our doctors do not make the diagnosis of constipation, and therefore sometimes these patients who are constipated go on without getting the appropriate treatment. So when you see a patient with recurrent abdominal pain or chronic abdominal pain, the first thing that you need to identify is this child having an organic pathology, or is this abdominal pain non-organic, or what we call a functional abdominal pain. So looking at the pain, there are certain characteristics in the pain itself which will direct you to a diagnosis of organic abdominal pain or organic pathology. So the main thing that I think, which is unfortunately going out of fashion, is taking a proper history and examining the patient. I think what we see is we try to over-rely on investigations rather than sticking to our basics of taking a proper history and examining these patients, especially in your private practice where your time is limited. I suggest that all of you have an examination bed in your practice, because these patients who are coming with abdominal pain needs to be examined properly, and of course take a good history. So as I said, this lecture is not going to have anything hi-fi or new knowledge for you probably, but I'm going to refresh your knowledge so that you take the proper history, and at least if you don't have time, have a specific or few questions that you always run through when you see these patients with abdominal pain. So the number one thing is if you go through a proper history and do the examination, if the child's growth is affected, if there's anything that you find in your examination which is not normal, then obviously you are thinking of an organic pathology. The pain itself, when you take the history first, if the pain is in a child who's less than 5 years, always think, can there be an organic pathology? Think of the possible underlying causes and take a good history. If the child has weight loss, especially recent weight loss, or has started losing weight after having a good weight gain in the initial periods, think of an underlying pathology. So we don't see much patients with celiac disease and so on, but it's good practice to always ask questions to exclude these underlying pathologies, because otherwise you're going to miss these. Of course, if a patient comes with fever and abdominal pain, you're always thinking of an underlying pathology, especially an infection, or whether there's something underlying. It might be a urinary infection, it might be something related to the gastrointestinal tract, it might be something like dengue fever, or so even these days chikungunya, where they have severe abdominal pain, and the child will complain mainly of abdominal pain, especially very young children who are less than 5 years, because that is the common thing that they say when there is pain, because it's difficult for them to interpret pain and localize pain. Of course, if there's bile or bile stain vomiting, you need to refer these patients to the surgeon. Jaundice, again, if you see jaundice, there is an underlying pathology. You need to refer these patients, and you should not be managing them on your own. But the important thing is to detect the jaundice. That's why I again would like to emphasize the importance of taking a proper history and examination. Again, 𝗦𝗨𝗕𝗦𝗖𝗥𝗕𝗘, as I said, you need to have an examination bed. You can't be examining a child who is running about or seated on the lap of the mother properly, especially when they come with a complaint of abdominal pain. Make sure that you examine properly, because we have seen, especially because I'm at Maharagama hospital, abdominal lumps being missed by our doctors, and these patients keep going, and ultimately actually the mother feels the lump and brings the child to the hospital. So I think that is not good on our part. So make sure that you examine properly. So if the child complains of back or flank pain, through your medical education, undergraduate education, that you are always thinking of an infection in the urinary tract. It might be a pyelonephritis, it might, especially if it's associated with fever, and so you have to do the necessary investigations in these children. So location other than the umbilicus, so most children will come. When you ask them where the pain is, they will show the umbilicus, which is the common thing to do. So that is, of course, a common thing. But if especially a child who's under 5 years shows you a place in the abdomen which is not in the umbilicus, another region, then you have to think of the underlying pathology. So always in my practice, I ask, if a child comes with pain, especially an older child, always ask the question whether the pain disturbs your sleep, because as with headaches, if the pain disturbs your sleep, it's likely to be a significant underlying pathology. So next I'll go to a few underlying causes which can cause recurrent abdominal pain. This is not a full list, and of course this is not put in a priority order. This is what I feel that we see mainly in our practice in Sri Lanka. So I will just go through a few of these. Of course, functional abdominal pain. So as I said, so first you take a good history, you examine the child. and then you are satisfied that there's unlikely to be something significant underlying. So always when you're dealing with children, you have to have a bit of knowledge about what is happening around them. For example, a 10-year-old coming 2 months before the scholarship exam with abdominal pain, headache is quite a common presentation. So you need to have that knowledge that a 10-year-old is going to sit for the scholarship exam and they are going to be under a lot of stress. So sometimes now we think when you say functional abdominal pain, that should not unduly cause discomfort to the patient. But the thing is, like organic abdominal pain, even the functional abdominal pain causes quite significant pain for the child and discomfort for the child. So you have to deal with these patients properly, talk to the parents, because sometimes when you talk to them only, you understand that they are not actually thinking about this functional aspect of abdominal pain. They always like to have a diagnosis with investigations, and you tell a kind of a big name for the diagnosis, they are happy, rather than when you say it might be associated with the stress. Because when I was in Puttlam, I had this patient who came with similar abdominal pain. I asked the mother, is she sitting for the scholarship exam? So she said yes. So is she unduly stressed? The mother's answer was no, we don't put any stress. So I asked the child, what time do you get up? 4 o'clock. What do you do? So 4 o'clock I get ready. Then by 5:30 I have to go for the tuition class. And then from there onwards I go to school, come back, have my lunch, go for a class. Then I do my homework, sleep at 2 o'clock. So you get time to play. No? So, and then mother says, no, it's not me, it's the teacher who actually wants her to do these things. So so you have to kind of highlight to them the issue. Then they are also sometimes ready to take action for this problem. So the same thing. So sometimes you have children coming with abdominal pain. So 3 months abdominal pain, and the mother has a 3-month-old baby on the lap. So you ask, how old is the baby? 3 months. When did the older child start complaining of abdominal pain? 3 months. So there's a relationship. So always see, look around, see what's happening. Ask where the father is. Father might have migrated. So these are all associated with stress in the child and can cause various presentations, including functional abdominal pain. And usually, remember, this is, as I said earlier, often periumbilical and non-specific. So then another, I think something that we don't see often in our practice is lactose intolerance. So again, the importance of taking a proper history. So you have a child who starts kind of having these bloating, gas, cramps, sometimes associated with diarrhea and abdominal pain. And if you take a proper history, you see that it is always associated with taking milk products or lactose containing food. So, and it's just a matter of identifying that and trying to get rid of that, and the patient will be totally fine, because what we see is abdominal pain for most of us, unfortunately, is gastritis. So don't make that diagnosis. Always think of the other possibilities. Ask a few questions to exclude this. And of course, parasitic infections or infestations. Again, certain parasitic infestations can cause bloating, gas, cramp, diarrhea, and so on. So this is, of course, very rarely missed, because the mother comes saying, so usually most doctors will start on the the worm treatment, but always, this is not very common, but of course, from if a child comes from poor socioeconomic background, look at the child. So those patients, you need to exclude these, but definitely overdiagnosed, usually diagnosed by the grandmother. Then, now this you see in cities, excessive fructose or sorbitol ingestion. So again, they come with abdominal pain, complaining of bloating. Sometimes the mother says has a lot of gas. And then you go through the history to see that the child, so most of these children, the father is abroad, so they send various candies, chocolates, and then they keep on eating these candy or sometimes fruit juices, and they might present with abdominal pain. Which ask a few questions to exclude these as well. So recurrent interception, this now usually when you say interception, for most of us, it's like an acute presentation where you have severe abdominal pain with blood, with recurrent jelly-like stools. But there is this rare patient who comes with abdominal pain, but it is typical where you have the drawing up of legs and complaining of or crying when there is pain, but it keeps going on and it continues for about a week or two sometimes. And you ask the typical things about the recurrent jelly stools, you examine, you find nothing, but the history is so suggestive. So when I was a registrar at Gurunagala, again, one of our colleagues, orthopedic doctor, he came with this his son saying, this pain has been there for some time. So, but it was typical from the history. It was a typical history of interception, but no other findings. We just did the scan, and it was an interception which has been there for some time. So urinary tract infections, again, this we don't miss that often, so that's good. So usually a patient coming with abdominal pain, most of us will ask a few questions to exclude a urinary infection. So you ask, so if it's a suprapubic pain, especially flank pain, most of us would do a urine full report. So I don't see many doctors missing a urine infection, but always keep that in mind. Patient coming with abdominal pain, you always think of urinary infection as well. Abdominal migraine, not very common, usually seen in children who are like less than 10 years, and it disappears when they reach puberty usually, and not always associated with headaches, but usually associated with nausea, vomiting, and there's a family history of migraine. So migraine usually, there's a very strong family history. About 70-75% of the patients will have a family history. So always think of these things. They are not very common, but if you have this patient who has been managed by others and by yourself, but still having abdominal pain, think of these uncommon things as well. So 𝗦𝗨𝗕𝗦𝗬𝗪, again, I think most of you would expect to see the typical abdominal pain with arthritis and a rash, and they will complain of having blood-stained urine or red color urine and so on. So if you do, some of them might have occult blood in stools as well. But there's this rare patient, about 1/3 of the patients with 𝗦𝗨𝗕𝗦𝗬𝗪 might present with just abdominal pain. So there's nothing else. So again, I think about a year back, I had this patient who had severe abdominal pain, but she also had constipation, treated for constipation. I treated her for constipation, then still not, the pain wasn't going away. Her father has died during the COVID days, so thought of some kind of a psychological issue, did the psychiatric referrals and so on. But the psychiatrist also prescribed medicine, but the pain never went away. So I did the investigations thinking of 𝗙𝗕𝗓𝗦𝗓𝗕𝗓, and you had a few red cells in the urine, and then of course made the diagnosis of 𝗙𝗕𝗓𝗦𝗓𝗧𝗓. But of course that patient later on went even to have an intestinal obstruction. So these rare cases can present to you. So just to know and appreciate that these type of presentations can also happen. And of course, this gastritis, peptic ulcer disease, of course, is the diagnosis most of us give a patient, a child coming with abdominal pain. So much so, the parent also comes saying, "Babada gastritis, බෙහෙත් කරන්නේ බෙහෙත පොඩ්ඩක් මාරු කරලා දෙන්න පුළුවන්." So that is so common. So, but remember, gastritis is not a common disease in children. So usually you have the typical features like burning epigastric pain, the pain worsens before meals, and usually it is relieved with antacids. So if somebody continues to have abdominal pain despite you prescribing these antacids, always think of other possibilities, because I see this is overdiagnosed in children, and especially in very young children, this is not a common thing, and therefore think of other possibilities. So then we come to this topic of chronic constipation. In my practice, I think most children who come with abdominal pain and who have this type of chronic abdominal pain are having constipation, and unfortunately, we do not diagnose constipation. So that's why I want to talk more about constipation, so that you always think and manage these patients appropriately, because otherwise they end up wasting a lot of time and money, and the parents are mentally down, and they are very stressed when their children have this kind of abdominal pain going on for months and months. So therefore, I'll talk a bit about constipation. So it is relatively common in children. So unlike gastritis, constipation is common. So about 5 to 30% of children will have constipation at some point. So the important thing is these children and their parents both have very poor quality of life because of this problem. So like about 3-4 days back also, I had a mother. She was like, "Doctor, mage mole හොඳටම දැන් අප්සෙට් ගහලා තියෙන්නේ මොකද බබාගේ මේ බඩ කැක්කුම නිසා මේක හොඳ වෙන්නෙම නැහැ. දැන් මට බෙහෙත් ගන්න වෙලා තියෙන්නේ." So they are very distressed with this. So especially when their child complains of abdominal pain, they don't know what to do. And the important thing is the pain perception in children are different. Some children will cry and howl in pain when they are like, even when they have a little diarrhea, and some children even with appendicitis will come calmly, and if you don't kind of examine the abdomen, you will miss an appendicitis. So therefore remember, sometimes even with constipation, the pain will be very, very severe, and these patients as well as parents are affected greatly. And this constipation results in frequent hospital admissions, because obviously now for you have this patient coming over and over again, so you don't know what is going on. So the next thing would be to refer, and they end up getting admitted, especially because sometimes they are in very severe pain. And of course, when you deal with children, school attendance is an important thing that we have to keep in mind. So these patients, again, the parents don't send the child to school, and when they go to school, the school nurse will call the mother and say, "The child is having abdominal pain. Do you want to come pick this child?" And then the mother has to stop her work, put leave, and go and collect the child from school. So these are common complaints that we hear. So that's why we have to deal with these problems in a better way. Always consider constipation in patients with disability and reduced mobility conditions such as Down syndrome, autism, cerebral palsy, and so on, because it's more common in these patients, especially because their mobility is reduced. The important thing is, unless you diagnose constipation and treat them appropriately, it becomes chronic in about 1/3 of patients, and chronic constipation is very difficult to treat. It keeps coming back, recurring, and children who are as old as 15, 16 years have swelling and abdominal pain. They miss school because of this. So it is important that you identify these patients at the proper time and treat them properly. So as I said, this is with all this significance, because of having a patient with constipation, you have to diagnose early, but it is definitely underdiagnosed. So why is it underdiagnosed? I think one thing is there's considerable variation in the normal bowel habits. Sometimes you have a child who goes to the toilet about 3 times a day, whereas another child might go every other day, and that might be normal for them. But remember, that's why you should not take the parents' word at face value. Sometimes they say, my child goes to the toilet 3 times a day. Why are you making a diagnosis of constipation? But the thing is, the child goes to the toilet 3 times, but because of the pain, they just sit there, wait for a little while, and come back. So that's why they keep going to the toilet. So sometimes a patient with constipation will give you a history that actually the patient goes to the toilet 3 times a day. So just because you get that history, don't forget about constipation. Just dig in a little bit, and then you will realize this patient, although he goes to the toilet, either just puts about 2 rapid droppings and comes out, or just sits there without passing stools. So that's why he's going 3 times a day. And then, so whatever the definition, so there are various definitions. So you have this Rome criteria. If you read the NICE guidelines, you have a different definition. So all these are relative definitions. Therefore, it's very difficult as clinicians, as practicing doctors, to kind of remember all these and make a diagnosis. Believe me, I think even I can't remember most of these definitions. And I think the main thing is to have use your common sense rather than sticking to these definitions. That is the best approach. And painful defecation is not always recognized. I think I manage so many patients with constipation, but none of them has come with the complaint of I'm having pain when defecation. The parents never say, Baba, kakka karna ko ridena kila andana. They never come like that. So it's something. So it's again a good practice to talk to the patient. So whatever usually when you have a child coming to you, you only talk to the parents, you take the history from them and you send them off. But just talk to the child as well. There have been so many occasions where the mother says, Baba, kisi ba kakkumak nahi, doctor hondara kakka kar lena, and then you ask the child, Baba, kakka kara redunada, oh. And then the mother's face also kind of changes because she never expected that answer. So always talk to the child when you're dealing with children. That will help. So now I think most of us, when you go for a party, you have so many people coming and telling you, I have gastritis, Dr. Gastritis, and all that. Nobody will come and tell you, doctor, constipated, because people don't talk about constipation and they don't actually want a diagnosis of constipation. They don't even think constipation is a proper diagnosis. So if the child is constipated, they think that is a normal thing, So they are always going behind some kind of a pathological diagnosis. And then as doctors, I think we don't think enough about constipation. I think that's why I wanted to kind of talk more about constipation so that you all also start thinking about this in your practice, ask questions, examine, always think this can cause quite significant disability in the child and manage them appropriately. So how do they come to you? So you read the textbook, they will give you, various things, but in Sri Lanka, the way they present is different. So I'm going to tell you a few ways they present. When they come like that, also you have to think of constipation. Of course, abdominal pain. So that's what we are talking about. Having chronic abdominal pain or recurrent abdominal pain is a common way of presentation. So initially, they will never tell you that the child was constipated. So they say child has abdominal pain. You say, okay, after examining, this child has constipation. There's like stool masses in the abdomen. And then the mother says, so that's how they tell. So they never come out with the history of constipation. So always consider that when a child comes with abdominal pain. So the other presentation is where the parents are worried about the foul smell. So they come and tell you, so that is the presentation. So they are talking about gas, and then you say, most of our doctors would say, and they send off, but without examining the abdomen to see this patient actually has constipation. That is why this presentation is there. So excessive flatulence, same thing. So again, they worry about the smell of the flatus. Excessive flatulence is also worrying for the parents. So that is one reason they bring to you. So when they bring to you with excessive flatulence, yes, there are certain food that can cause excessive flatulence, like all these food stuff. Especially cereals, but then always think about constipation as well. So take a dietary history just to see why he is getting this. Then this is something I think most books will not tell you, and this is quite a common presentation in young children. They come to you with increased urine frequency. So the parents say there's increased urine frequency. So most of our doctors will do the urine full report and sometimes the culture and start them on antibiotics, but nothing happens. So this is when the patient presents to me, because now they have taken treatment from the GP and the urine full report is completely normal, but we have still given antibiotics and the symptoms are still going on. So then when you ask about the bowel habits, then you find that the patient is also constipated, and sometimes you just need to treat the constipation and then you get them to come back in 1 week's time, and the parents are very happy saying, yes, doctor, now this urine frequency has also settled. And of course, urinary tract infections. So, when a child is constipated, they are at greater risk of getting urinary tract infection. So if you have a child who has not had any urinary infections in the past, suddenly coming around 2-3 years of age with urinary infections, always in your history, talk about the bowel habits, see whether the patient is constipated, because if you do not treat the constipation, this patient will keep coming to you with recurrent urinary infections, and therefore you have not treated the patient properly if you don't treat the constipation as well. Then the main concern for the parent might be the child going to a corner of the room, kind of straining. They say the child is trying to pass stools, but it's so painful, he can't pass. But actually what is happening is the child is trying to retain the stools rather than pass in the stools. They don't like to go to the toilet or the potty because they are scared there will be pain, so they are withholding the stools. So soiling or overflow. Now this again we tend to miss, especially when the parents come to you. The parents say, "Babata badeliana," right? So then you always think, okay, this is diarrhea. You start treating for the diarrheal illness, and but the diarrhea doesn't go away. So I will just tell you about two patients that I had, just to kind of emphasize the importance. So there was like a 15-year-old boy who had diarrhea, according to the mother, a medical person, that has been there for over 2 months. Treated by a GP with antibiotics, it never went away. So now why the patient was with me is because now they are planning to go on a trip, and this 15-year-old is refusing to go on the trip because he's having this chronic diarrhea. And examine the abdomen, fully loaded with stools, and you basically treated the constipation. The child was fine and went on the trip. So then another patient again, so admitted to one of our teaching hospitals, again with diarrhea, so-called diarrhea, and treated for 5 days with IV antibiotics in the hospital. So the history taken by the house officers, I'm sure the senior house officers, registrars, senior registrars are also in that hospital. Treated for 5 days, and discharged after treating for the diarrhea. Came to me after 3 days again with diarrhea. Then to see this patient is having constipation, severe constipation with overflow, only needed treatment for the constipation, and the child was very happy. The parents went so happy because they have spent so much on money being in hospital for 5 days, given IV antibiotics, and ultimately they have missed the diagnosis. So always, just because they come and say it's a diarrhea, always ask what is the consistency, is it watery? Because usually this overflow is not watery stools, it's like semi-solid stools. And you can ask, what I do is I ask sometimes, do you have control over the stools? So most of them will say there's just staining of the undergarments, there's no control. So that is because of the overflow. And then of course you need to treat the constipation. And then the presentation might be with distension or discomfort. Again, especially in young children, they bring the child saying, "Babage pada luku vela." So that is the presentation, to see fully loaded with stools. And again, now I'm sure if you all are seeing children, this is another common presentation, poor appetite. Always, even obese children, they will say, "Baba khanne nahi doctor," and they want a vitamin. But then, of course, most of the time, the poor appetite is because they are being given junk food and various drinks and so on. But then there is this one patient who is having poor appetite because of constipation, and he basically doesn't want to eat because the abdomen is full of stools. And then another diagnosis made by the grandmother, itching at the anus. So babata panu amaroට බෙහෙත් තරන් ඉන්න. So the mother comes and tells you, මේ අම්මා කිව්වා මෙයාට පණු අමාරුව එන්නේ නැති ડોක්ටර් මේ පස්ස කහනවා. Actually පස්ස කහන්න හේතුව is either because there is overflow and soiling, or because the patient is having pain there, and the young child is always feeling the anus because of the pain. So, and then of course you examine, you find the stools, and you have to evacuate the stools. And of course, one of the most popular ways the parents bring you a constipated child is babata gastritis. It has been treated for gastritis by so many doctors, and but it's not going away. So they want you to give this miracle medicine or the latest medicine to get rid of the gastritis. But the problem is the patient never had gastritis. So what next? Obviously, about 5% of children will have an anatomical or physiological cause is found in only less than 5%. So all of the others will be having functional constipation. But when you take the history, especially if you are seeing this patient for the first time, look for the red flag signs such as delayed passage of meconium as a neonate, ribbon-like stools, growth faltering, lower limb weakness, gross motor delay, then abdominal distension or vomiting. Usually, although when you say vomiting, you are always thinking of a pathological cause. Believe me, there are even functional constipation patients who come with vomiting when it is very severe. So don't exclude a functional constipation just because the child has vomiting. And then, of course, the fissures, fistulae, look for those. And then look at the spine if there's any asymmetry, sinuses, lipomas, etc. So I had the privilege of working with two very good clinicians when I was a registrar. One was Dr. Gunathilaka and other was Dr. 𝗙𝗦𝗕𝗦𝗪𝗢𝗪. So if we got a patient with constipation as a registrar, we had to always examine the lower limbs, look at the spine, unless otherwise they were not very happy. So, and that of course is still valid when you manage these patients. Look for lower limb deformities, look for reflexes. So when you see these patients the first time, look for these. And of course, if you see this, you have to do the referrals accordingly. So as I said, don't think too much about the definitions. So most of them use the Rome form criteria, especially in research settings. So don't worry about that. You can read that up. So this is something that I use quite often with parents and the patients. So when you ask what happens or whether your stools are hard or not, most of them don't are confident to tell you what type of stool they have. You show the Bristol stool chart, and if they say it's like rapid droppings, the type 1, it's severe constipation, and you can tell the parents with confidence that this is constipation. So then when you make a diagnosis of constipation, the next question the parents will ask you is, why did my child get constipated? So generally, this is one reason, toilet training. So they will, now actually yesterday also I had this child, 1 year, 3 months. So I asked the question from the mother, Babata, then toilet එකේ යන්නේ ගොඩක් කලින්ද toilet එකේ තමයි යන්නේ. So that means, so they have been trying to toilet train the child from 9 months. So which is the child's brain development is not appropriate to do that. So therefore, that is the reason. So I explained to them this should not have been done. And managed. I'll have to see them again. So this is a common thing. That's why most of them come around this age with constipation, around between 1 to 2 years, where they complain of these issues. Then the next thing is, now you have a patient who gets an infection. So let's say dengue infection, goes to hospital. The patient is in a new unfamiliar surrounding. They don't want to use the toilets because of the fever. They are dehydrated, in pain. So they don't pass stools. And then they are discharged from hospital. And then as a GP, you see them after about a week's time coming with abdominal pain. So that is because now they have got constipated. So, but if you miss this constipation, then this becomes a chronic constipation. So that's why if you get follow-up patients like that after an infection, or for some reason they have had abdominal pain. For example, if they go on a trip, the patient doesn't want to go to the toilets there, so then they come back with constipation, so don't miss those. And then one of the commonest things that I see is this school vans. So the school van from, let's say, Maharagama leaves at 5:30 to come to Colombo school. So the child doesn't have time to go to the toilet. They come to school. They don't want to use the toilet at school also. Then they retain. Once you start retaining, it's very difficult to pass the stools, and then they have constipation. So with the swimmers, they are training at 5 o'clock in the morning, don't have time to go to the toilet. They wake up at 5, runs to the pool, because otherwise they are punished by the coaches. And again, scholarship exams will do the same. So always take a history and see. Then of course diet. If you see these children who are between 1 and 2 years are usually eating lots of chocolates, biscuits, nothing which is high in fiber. So obviously they get constipated. And remember, what we give, drugs can cause constipation. Antihistamine, proton pump inhibitors. You imagine a child comes with constipation, you make a diagnosis of gastritis, you give proton pump inhibitors, the constipation gets worse. So, and these days, you see like almost all children, all patients are on vitamin D. So think of what you're prescribing as well. So management, I've told this enough today. Take a good history and examine. First decide whether the patient has constipation or not. If constipated, think whether it's functional or does he have an underlying cause. If the patient has an underlying cause, refer the patient to the appropriate specialty. If you think it's functional, is the patient having impacted stools or not? If the patient has impaction, what are you going to use as the disinfection medication, and what are you going to use as the maintenance medication? You have to communicate with the patient's parents regarding the diagnosis. It's very difficult, believe me, but you have to talk to them, otherwise they will not take this diagnosis seriously. Give evidence-based written information. It has to be culturally appropriate and tailored to the patient, because you can't be telling a patient who's going in a school van, you can't tell them, okay, go in the morning, and the same thing you can't tell them, because then best time might be after school, so you have to train them for that. Investigations, usually you don't need many. Abdominal x-rays and ultrasound should not be done to diagnose idiopathic constipation. So I think a lot of you all cannot do x-rays, but it should not be done. So testing for celiac disease, hypothyroidism is recommended only if the history and examination shows evidence of growth failure or intractable constipation. So I think most of them, when I see, usually have a thyroid test done. I think there's no harm, but generally you don't need to. And then, of course, if you feel this patient needs endoscopy or manometry, biopsy, etc., you have to refer them appropriately. You should not be managing these patients. So then medical management, disinfection. So usually if you use Western books, they will say polyethylene glycol plus electrolytes, or Movicol. You give it according to an escalating dose regime up to 2 weeks. But remember, in our patients, you use this, they will go to the next doctor saying, 𝗙𝗢𝗟𝗟𝗢𝗪, because usually this increases symptoms, increases the soiling, increases the abdominal pain before it gets better. So unfortunately, in our system, parents don't kind of tolerate this type of thing. Although you explain to them, still they don't want to go through 2 weeks of disinfection regime. They will not come to you again. So enemas, So that is what I generally use because of that. So sodium citrate enemas are preferred over the phosphate enemas. So the phosphate enemas are the ones like the clean enemas, which we usually don't use in children. So then maintenance, so once you do the disinfection, you go on to the maintenance treatment. So you can use movicol or polyethylene glycol with electrolytes, lactulose, so it depends. So the thing is, generally you have to continue the medication for several weeks after regular bowel habits or toilet training is well established. So this is something again which I see that you all don't do. Sometimes when you make the diagnosis of constipation, you just prescribe the stool softener for about a week. That's it. As soon as the bowel opens properly, the mother stops the maintenance treatment, and then after 1 or 2 months they keep coming back to you. So you have to tell them you should not stop abruptly. Actually, one of the latest articles I read, what they have said is, if the child is constipated for 1 month, you have to give the maintenance treatment for 1 month. If the child is constipated for 3 months, you have to give for 3 months. Like that, the number of months or days or years, ideally, if they were constipated, you have to treat for a longer period, depending on how long they were constipated. So you have to stress on that. Do not stop the maintenance treatment when the child is passing stools properly. So diet and lifestyle, do not use dietary interventions as the first line always. You have to use diet plus the laxatives have used. So, but remember, you have to also use non-punitive behavior interventions suited for age. So you're not going to start a star chart for a 15-year-old, but it might be a good way to manage a child who is 5 or 6 years or even 4 years. They would like to have a star chart. And then scheduled toileting, what I generally tell parents is, use the gastrocolic reflex. So after they have a main meal, you can ask them to get the child to sit on the toilet, and that is a good way of toilet training. Bowel diary, I don't think our parents really don't do that properly, but sometimes I tell them, okay, you write when they have the constipation or how many days they go without passing stools. That helps. And then encouragement and rewards. Then it is very important to do the dietary modifications, balanced diet, sufficient fluids. I think one person who is very keen in this topic is Professor 𝗙𝗢𝗟𝗟𝗢𝗪. He always says, if you give too much of water, it will go as urine. It will not help with your constipation, but I think you need to give a sufficient amount of fluid, not excess. And of course, stress on the adequate physical activity, because you see children who sit in front of the TV or always on games or on bed will obviously get constipated. Children who go out, play, do physical activity are less likely to have constipation. Okay, so I think we can, if you all have any questions, I'm happy to answer the questions. Okay, good. Right, so I think, as I said earlier, I think it's a very basic thing. Just to refresh your knowledge, I don't think I mentioned anything new or anything that you all didn't know. So hopefully this helps you in managing children, especially with abdominal pain, who I think makes quite a big proportion of your pediatric patients. And thank you for listening.
Thank you so much for that refined lecture. It took us back to the basics, but also gave us a much needed practical perspective in approaching child with recurrent abdominal pain. So that's it for today. We'll be meeting you back again with such an interesting topic on the 19th of this month as well. So thank you so much, sir. Hope we could bring you back with us with such interesting lectures. Thank you all.